Hi, welcome everyone. I'm Anita Chong. I'm a transplant immunologist from the University of Chicago, and I will be the moderator of this webinar. On behalf of the presenters, I want to thank all of you for your interest in attending this webinar that is organized by the Transplant Diagnostics Community of Practice. And the topic for today is CD38 targeting agents, along with co-stimulation blockade in this new era of desensitization. We have nearly 300 registrants who are eagerly awaiting to hear from two renowned experts on this topic, Dr. Ashley Vo and Dr. Flavio Vincenti. First to present is Dr. Vo, who is the Administrative Director of the Transplant Immunotherapy Program at Cedars-Sinai and Professor of Pediatrics at the UCLA School of Medicine. Dr. Vo's research interest is in advancing desensitization for highly sensitized patients awaiting kidney transplant. So she will first discuss her experience with this anti-CD38 desensitization. So Dr. Vo, take it away.
Thank you so much, Dr. Chong, and good morning and good afternoon to everyone. First, I would like to thank the AST for the invitation to speak to you today on this important topic. This is my disclosure. And the objectives of today's presentation is to evaluate the use of anti-CD38 as a desensitization agent for HLA-sensitized patients, to discuss our center's experience in identifying and selecting an HLA-sensitized patients who would likely benefit from daratumumab desensitization, and then to share with you our outcomes. So as we all know, strategies to address the unmet needs for the hard-to-transplant patients have included prioritization within the deceased donor kidney allocation system, transplantation through acceptable mismatch programs, and living donor pair exchange. However, even with the advent of kidney pair donation and living donor desensitization options, these interventions have not increased access for those with CPRA of more than 99.9. Current strategies to control HLA antibodies are ineffective, mostly due to their inability to persistently deplete or inactivate the mature and likely long-lived plasma cells that are the source of HLA antibodies. And so advancement with anti-CD38 has the potential to change treatment landscape of antibody-mediated diseases and potentially a therapeutic option for HLA desensitization. Shin Sakayao asked the question, is there still a role for desensitization in managing the highly sensitized patients in the era of kidney pair donation and new kidney allocation? And in order to ask or answer that question, they looked at the UNO-STAR file in a cohort of patients that were waitlisted in June 2016, who were followed for 1 year. And they show that the overall transplant rate was 18.9%. Only 9.7% transplanted were with CPRA more than 99.9. And among the CPRA that were more than 99.5, looking at the rate of transplant for a living donor, that rate was only 2.5%. And nearly 4 years after KAS implementation, approximately 1,800 active waitlisted patients had CPRA more than 99.9, and 35% of those patients had more than 5 years of wait time. So despite the KAS and KPD, the sensitized patients that are with CPRA more than 99.9 still did not have access, improvement to transplant, and the authors felt that desensitization would benefit these patients in order to improve their ability to receive a transplant. Moderator also looked at the rate of transplant for this group of patients by granular CPRA, and actually they look at the CPRA group of 95 to 100%, but if you look at the 99.9 and greater, the rate of transplant was very low despite the national allocation priority. So current strategies for desensitization include combination of pheresis and low-dose IVIG, high-dose IVIG with or without pheresis, and anti-CD20. And the overall aims in these patients are to improve the chances of successful kidney transplantation and to decrease the short and long-term risk of rejection. However, there's a lack of consensus on the effectiveness of various available regimens in reducing the HLA antibodies in this group of patients. So in this paper, we discuss advances in desensitization for HLA-incompatible kidney transplantation, and we show therapeutic options for prevention and treatment of AMR, as well as in conjunction with their targeted alloantigen activation and effector pathways. So as we all know, the major pathogenic factors are the high affinity IgG complement activating DSA. And in the initial alloantigen activation that leads to T cell activation, this step can be blocked by CTLA-4 Ig or anti-CD28. But importantly, these co-stimulatory blockers are also potent inhibitors of the germinal center TFH activity that can prevent the primary immune response that's induced by alloantigens. Next, with the anti-IL-6 therapy, such as tocilizumab or clazakizumab, these can block the activation of IL-6-induced TFH and Th17 as well as plasmablasts. And then anti-plasma cell therapy, such as the anti-CD38 daratumumab, anisetuximab, or the BCMA bispecific CD3, Regeneron 5459, can block the plasma cells. And other therapies that are listed here are also shown. But for the purpose of today's presentation, I'm going to focus on the anti-CD38. And what our findings has shown or indicated is that combining these antibody reduction therapy along with inhibition of B cell activation and plasma cell DSA production represents an achievable pathway for prevention and treatment of AMR. Dr. Vincenti and Dr. Chandran, who is now with us, published this mini review on anti-plasma cell antibody as a new era for controlling HLA antigen in solid organ transplant. So briefly, CD38 is a 45 kilodalton type 2 transmembrane glycoprotein that mobilizes intracellular calcium and regulates signaling. CD38 interacts with CD31 as main ligand to induce leukocyte activation, proliferation, and transendothelial migration, as well as B cell differentiation. And CD38 expression is highest on plasma cells, but also expressed on the early NK cells, early B cells, red blood cells, and platelets. And in this figure A cartoon, when plasma cell depletion is given alone, what would happen is it would lead to the expansion of TFH and germinal B cells that will lead to a compensatory humoral response that will lead to a rebound of HLA. However, in figure B, if we use a strategy to dual target both the plasma cells and the costimulation blockade, that will prevent the compensatory humoral response as well as preventing the HLA rebound that is seen with plasma cell depletion alone. And there are now some trials that are investigating that the dual strategy that will be discussed by Dr. Vincenti when he presents his part of the presentation. The initial experience with daratumumab in sensitized kidney transplantation was in the non-human primate model. Here you can see that with the monkeys, rhesus monkeys, they were sensitized by skin grafting, and they were desensitized with daratumumab plus plerixafor compared to the control. And with daratumumab and plerixafor, there was a significant reduction in the DSA as well as improved graft survival with the those that were treated with daratumumab and plerixafor, their graft survival was 28 days versus 5.2 days in the control. However, with the reduction of the DSA, this reduction was not maintained. They also treated two patients with daratumumab. One was a kidney transplant patient who developed antibody-mediated rejection that was resistant to standard therapy. And a second patient was a sensitized patient who was awaiting for a heart transplant. And what they showed was that there was a significant reduction in both class 1 and class 2 DSA that led to clinical improvement of ABMR in the kidney transplant patient and increase in heart transplant access for the sensitized heart transplant candidate. So they concluded that the daratumumab desensitization merits investigation as a potential therapeutic strategy, although further research would be needed. Clinical trials for desensitization with anti-CD38 are listed here. The COMBAT trial was conducted in France. This was a combination of daratumumab with belatacept in highly sensitized patients with CPRA of more than 99%. The patients would have to be on a deceased donor kidney transplant waitlist who have not received a compatible donor offer for more than 3 years. This was a two-step trial. The first step is to treat patients with belatacept, and if ineffective, 4 sessions of pheresis followed by daratumumab monotherapy in step 2. The study started recruitment in January 2022 with an estimated completion of November 2025. The second trial is the DARDAR trial that was conducted in the US, and it was to assess daratumumab-based desensitization before kidney transplantation. They investigate daratumumab dose escalation from 4 milligram per kilo to 8 milligram per kilo to 60 milligram per kilo in step 1, and then full dose 60 milligram per kilo in step 2 in patients with CPRA of more than 95%. And the third trial is the isatuximab monotherapy for desensitization by Dr. Vincenti et al., and he will also present this data for you when he presents his part of the presentation. So briefly with the DARDAR trial, this was a open-label phase 1/2 study of daratumumab-based desensitization. This was a two-phase study. The phase 1 was to evaluate the safety of daratumumab at doses that were double once every 4 weeks over a 3-dose interval, 4 milligram per kilo weekly times 4 to 8 milligram per kilo weekly times 4 to 16 milligram per kilo. Then the phase 2 was to assess daratumumab full dose 60 milligram per kilo weekly times 8 weeks, and patients were followed for 12 months after the first infusion. The parameters that were evaluated were CPRA with an MFI of 2,000, CPRA with an MFI of 10,000, the number of anti-HLA, MFI max, and MFI sum. And what was seen with the DARA desensitization was that there was no significant reduction seen with the CPRA of 2,000 MFI. However, there were significant reduction with the CPRA MFI of 10,000, number of anti-HLA, MFI max, and MFI sum at month 3 post-treatment. However, these parameters return to baseline levels at month 12. Thus, the authors or the study concluded that the daratumumab for desensitization did show reduction in anti-HLA antibodies, but it was only transient, and that only 40% of the patients or the responder had durable response, and therefore limit its potential clinical use in desensitization. So what I'd like to do now is to share with you our center's experience with daratumumab. But before I start, I would like to share with you this case to show you how we identify a patient who would benefit from daratumumab desensitization. So this was a 60-year-old patient who had end-stage renal disease secondary to lupus, who had received a first transplant that was living unrelated in 2008, but lost as transplant due to rejection. Her sensitizing events included a previous transplant, 2 pregnancies, and blood transfusions. She had her class 1 of 100% and class 2 100% by LSA with a CPRA of 99.99. In addition, she had AT1 receptor antibody that was strong. She underwent several rounds of desensitization. Her first round was with pheresis, IVIG, and tocilizumab monthly for 6 months. Then 6 months later, she underwent a second round of desensitization with pheresis times 5 IVIG and daratumumab weekly times 4 doses. And then about a year later, she underwent a third round of desensitization with pheresis, IVIG, and obinutuzumab every 14 days times 2 doses. That was completed in May 2022. 6 months later, she was enrolled in the Hansa Confidus study, and about a year later, she received a deceased donor kidney transplant number 2 in October 2023. Her donor was a 39-year-old male. Cause of death was head trauma. Admit creatinine was 0.64 and terminal creatinine was 1.06 milligram per deciliter. Her OPO flow cross-match is as shown. She had a positive T flow with 240 mean channel shifts that was pronase treated, negative was 70 pronase, and a B flow that was 386 mean channel shift pronase treated, and negative was 130 pronase. She also had 4 DSA, 2 class 2 that were strong, a moderate class 1, and a weak class 2. She received induction with thymo and then post-transplant anti-CD20 and IVIG as part of the HANSA study protocol. Post-op course did not require dialysis. She had excellent urine output with a creatinine on discharge of 1.19 milligram per deciliter. So here is our algorithm for management of the highly sensitized patient at Cedars-Sinai. When the patient has CPRA of 50 to 98, they receive anti-CD20 and IVIG as a desensitization protocol. If their CPRA is greater than 99, they would receive pheresis times 5 IVIG followed by an anti-CD20 1 week after IVIG. Now, if 6 to 12 months after completion of desensitization and they're not transplanted, then we will retreat them with another round of pheresis, IVIG, and anti-CD20, or pheresis, IVIG, and anti-IL-6 monthly for 6 months. Our induction protocol is with alemtuzumab, and this is our post-transplant protocol with IVIG and anti-CD20 to prevent the rebound. About 5 years ago, we started using anti-CD38 as another option for retreatment in our sensitized patient. So the protocol include pheresis every other day times 5 sessions. Then at the end of the 5th pheresis, we give 1 high-dose IVIG, 2 grams per kilogram, and then we wait 1 week later to start daratumumab. The reason why we wait 1 week later is to minimize the FcRn interaction between IVIG and another monoclonal antibody. So daratumumab was given weekly times 4 in the sub-Q route, and then we wait for a transplant, and then this is our post-transplant protocol. So from September 2020 to November 2023, we desensitized 10 broadly sensitized patients. This table 1 shows their baseline and transplant characteristics. Of the 10 patients, the mean age was 59.5. 60% of the patients were women with a mean HLA match of 3.5 plus or minus 1.25. The time from dialysis to transplant ranged from 31 months to 169 months. This patient 5 was a patient that I presented to you in the case. Time from last DARA to transplant ranged from 1 month to 29 months in patient number 5 and 30 months in patient number 10. The mean MFI at baseline for class 1 and class 2 for the individual patients are shown here, but I will show you in more detail on the next slide. 9 of the 10 patients receive induction with CAMPath, and at the last follow-up, 9 of the 10 patients are alive and well. This patient number 4 expired 12 months after transplant due to a CNS lymphoma. Table 2 shows the waitlist immunologic characteristics of the 10 patients that were desensitized and transplanted after the daratumumab protocol. All patients had a previous transplant. 6 of the 10 patients had CPRA that's more than 99%. And then flow cross match are also shown here. If you look at the patient 8, 9, and 10, they had CPR that's more than 99%. They had a negative cross match with their donor. However, you look at patient number 10, this patient received a 0 mismatch kidney with a negative cross match, but the transplant occurred 30 months after the last DARA treatment. So here we look at the effect of daratumumab on the mean MFI for class 1 and class 2 from baseline to transplant. Here is the mean MFI class 1 at baseline, 1 month post-DARA, 3 to 6 month post-DARA, and at transplant. So for example, when you look at patient number 3, we did see a pretty robust reduction of the MFI class 1, 1 month after DARA. And we saw some more reduction at 3 to 6 months post-DARA, and then at the time of transplant, it remained about the same. Other patients, though, we saw some reduction, but not as pronounced. There are a few patients that receive a transplant 1 month post-DARA, so you don't see, for example, patient number 6, there was no gray bar that is seen, patient number 7 and patient number 9, even though there was not as much reduction seen. With regards to MFI class 2, so again, patient number 3 had some reduction with MFI class 2, but not as pronounced as that of the MFI class 1. And then other patients that are shown here did have some reduction, but at the time of transplant, there was rebound associated. So these patients, 8 of the 10 patients had received a transplant within 12 months post-DARA. The other 2 patients received a transplant more than 12 months post-DARA treatment. Here we look at the effect of daratumumab on the percent change in MFI from for class 1 and class 2 from baseline to versus at transplant. So here's patient number 3 again. There was a very robust reduction seen for MFI class 1, and similarly for patient number 2. But with MFI class 2, there were some reduction seen, but it was not as pronounced. And then for patient number 9 and number 10, this patient had a rebound of the MFI class 1 and class 2 after the treatment that was seen. The patient, again, did receive a transplant 30 months after the last DARA. This was a 0 mismatch kidney with a negative cross-match. Here's patient number 5, did have some reduction, but again, waited about 29 months after the last DARA to receive a transplant. Of the 10 patients that we transplanted, there were 6 patients that had DSA. Here we look at the effect of daratumumab on DSA pre-desensitization, at transplant, and out to 24 months post-transplant. And when we look at the individual patients of the 6 patients that had DSA, these are the effect of daratumumab on their DSA pre-desensitization out to 24 months post-transplant. So this patient number 1 had 3 DSA at the time of transplant, but at the last follow-up at 24 months, the A23 is still present, but it's about 2,000 MFI. Patient number 5, as the case was presented in the case study, this patient had 4 DSA at the time of transplant with a positive cross-match. 12-month post-transplant, this DQA104 was still present, but only at a 2,000 MFI. And the patient did have a de novo DSA that was a CW7 that occurred at 12-month post-transplant, and this DSA is about 2,500 MFI. The other patients that are shown here did not have any detectable DSA post-transplant at the last follow-up. Time to rejection is also shown here. There were 4 patients with rejection. Patient number 2 had a mixed rejection at 6 months post-transplant. This patient did not have detectable DSA, but did have AT1 receptor antibody strong. Patient number 5 had AMR at 14 days post-transplant. This was expected. Patient had a positive cross-match with 4 DSA at the time of transplant, and 2 of the class 2 that were strong rebounded after transplant. So she had AMR 14-day, responded to treatment, fortunately. Patient number 7 has CMR1B at 7 months post-transplant, and patient number 9 has CMR2A at 1.5 months post-transplant. Both patients responded to thymoglobulin treatment. Here we show the individual eGFR and mean eGFR from transplant up to 24 months post-transplant. Most of the patients did have a 12-month follow-up with an eGFR that is shown here, and 3 patients had eGFR out to 24 months. A mean eGFR at 12 months was around 63 ml per minute per meter square, and at 24 months around 50 ml per minute per meter square. So in summary, many strategies have been utilized to address the unmet medical needs for highly sensitized patients. Agents aimed at eliminating long-lived plasma cells are likely to benefit, and daratumumab represents an emerging therapeutic for desensitization in patients with CPRA of more than 99.9. Our data show daratumumab was associated with reduced DSA MFI strength, allow for HLA incompatible transplantation in 10 patients, and was relatively safe. And therefore, after many years of limited options, advanced therapeutics will likely improve efficacy of desensitization and improve access to kidney transplantation for the very hard to transplant subset of highly sensitized patients. With that, I would like to acknowledge our team at Cedars-Sinai for their untiring effort. On behalf of our patients, but specifically Dr. Jordan, our medical director, for the brain behind the scene, who have investigated all these advances in therapeutics that allow our patients the opportunity to receive a life-saving kidney transplant. Thank you very much.
Thank you, Dr. Vo, for the outstanding overview and the very exciting results with this very difficult population of highly sensitized patients. I forgot to mention for the audience, please use the Q&A instead of the chat option for questions that we will following both presentations. So next, we will hear from Dr. Flavio Vincenti, who is the professor of medicine at UCSF. Dr. Vincenti's main interest is in translating early immunological targets into successful clinical trials in kidney transplantation. He has led pivotal trials for daclizumab and belatacept and is currently the PI on an ITN trial to desensitize highly sensitized patients with anti-CD38 and belatacept. He will discuss results of this trial and also on some new results with BCMA CD3 bispecific antibodies. So Dr. Vincenti.
Thank you, Dr. Chong. And these are my disclosures. And I think, as you've heard, that the patients who are highly sensitized, that represent 30% of patients between CPRA 99 and 100% who have a CPRA of 99.95, have not benefited from the kidney allocation system. And those are the ones that the FDA actually is really interested in desensitization trial because they consider these as an unmet need. Now, the novel drugs for multiple myeloma are ushering the way to better targeted therapy for both desensitization and for control of AMR. And this is one of the figures from our recent review of the anti-CD38 and BCMA in the American Journal of Transplantation. And while it shows that there are multiple potential targets that have been used to control to treat desensitization and AMR, in fact, it is the long-lived plasma cells that is the most potentially effective targets. And until multiple myeloma therapy advanced, we did not have the best tool to control HLA antibodies. And the two targets on plasma cells is, as you've heard from Dr. Vo, is a CD38 protein. It's a glycoprotein that's important in signaling, as well as a BCMA, which is a receptor which is critical for differentiation, survival, and proliferation of plasma cells. Now, currently, there are at least 4 anti-CD38 antibodies. Daratumumab was the first one approved for multiple myeloma. The next was isatuximab. 2 other ones are in clinical trials, felzartamab and megazitamab, and there are a couple of others that are also hovering below the surface. Now, these anti-CD38 antibodies target different epitopes on CD38, and they are not exactly the same. For example, while in general they all may have antibody-dependent cytotoxicity and antibody-dependent phagocytosis, some may not have complement-dependent cytotoxicity like felzartamab. And only isatuximab has apoptosis, direct apoptosis of the plasma cell, doesn't require secondary cross-linking like the other ones. I will discuss the bispecific anti-BCMA later on. So now, this slide shows the reason why we have not been very successful using anti-CD28, whether rituximab or second generation. Because with anti-CD20, with anti-CD20, we only target B cells. And it's only by going after the targets by going after the CD38 target and BCMA that we can actually eliminate those plasma cells, especially the long-lived plasma cells that are presumed to be the main cells producing HLA antibodies. And I think one of the studies that I'd like to show, limited as it is, to give you an idea about the limitation of going after B cell. This is a study in lymphoma patients and multiple myeloma where they use CAR T cell for CD19 and BCMA. Now, in the study for the CAR T CD19 in lymphoma patients, there were several patients who pre-CAR T therapy had HLA antibodies. And despite the elimination of the B cells that you can see with the CAR T, those HLA antibodies persisted, suggesting that you really need to go beyond the B cell and the plasma cell. And I think some of the data in this one of the first studies in non-human primates was described to you by Dr. Vo, that it just using daratumumab was effective, but had limited use because the response was not durable. And one concern that the author raised was that the potential depletion of Tregs with increase in cytotoxic T lymphocyte and memory T cells, which is good to control cancer, may be counterproductive and induce cellular rejection. Although, one case was reported, I think, by the group at Cedars-Sinai. I don't think that has I don't think that's going to be a problem, and I'll show you why. Now, in 2017, as I got interested in the anti-CD38, I approached Sanofi with a design to do monotherapy with their anti-CD38 isatuximab. It took like a couple of years to convince. I mean, the problem with these developments is that isatuximab is controlled by hem-oncologists and not the transplant people at at Sanofi, and so it took quite a while to convince them. Finally, they did pursue the study, but they wanted to do the study as a multi-center trial, which was great. So we had 23 patients that were enrolled in two different cohorts. One had lower CPRA than the other one, but they both approached basically 99.9 or higher. And the patients were treated with 10 milligram per kilo of isatuximab in 3 cycles, so a total of eight infusions, and then were followed. Now, the efficacy of desensitization in this study, the primary endpoint was the response rate, and the response rate defined at the end of 26 weeks was one, whether there was a reduction of CPRA resulting in at least 100% in likelihood of finding a compatible kidney. I think this is really, and there was an editorial in JSON that suggested this may be one of the better endpoints of desensitization. Number 2 was related to that reduction in antibody titer to achieve target CPRA. And the third one is elimination at least one HLA antibody greater than MFI 3000 to below 2000 so that it could be crossed for transplantation. The results of the study showed that with the anti-CD38, there was decreased CD38 plasma blasts and plasma cells and AK cell in circulation. In fact, we looked at Tregs, and Tregs overall were not decreased. The CD38 Tregs were decreased. The CD8 positive Tregs were decreased. The CD38 negative Tregs increased so that ultimately the total Tregs were the same. Now, we are currently doing functional study to see what is the difference between Tregs that are CD38 positive and negative. There was reduced HLA-specific IgG memory B cell secretion, and the proportion of patients who achieved the target CPRA level, meaning doubling the likelihood that they get an offer, was about 33 to 45%. Of the patients that got treated, 6 out of the 23, 6 received transplant offers, and 4 were accepted. And of those 4, 2 were from previously incompatible kidneys. So this was an interesting first step because it was just monotherapy to assess what anti-CD38 on its own could do. While we were doing this trial, the ITN had an RFA for regimens to induce B cell tolerance. So we thought desensitization could fit into the RFA. And so our hypothesis was to use plasma cell depletion and co-stimulation blockade, both to reduce HLA antibodies at the same time induce some degree of B cell tolerance and increase rate of kidney transplantation. Now, our study were based on experimental trials. So this is sort of a model of a translational design of a study. Now, Stuart Konecny, as well others, had shown that when you use bortezomib in non-human primates, for example, you do deplete plasma cells, but you don't decrease HLA antibodies. And I think clinically, the use of proteasome inhibitors has not decreased HLA antibody much. What's interesting is that what they found that there is humoral compensation occurring after plasma cell depletion. There is rapid but transient induction of circulating B cell and marked increase in germinal centers. And you can see here before and after. And this what happened is that the HLA antibodies did not decrease because the new B cells started to produce these antibodies. So the concept of dual therapy came up to eliminate plasma cells, at the same time use belatacept to prevent activation of the T follicular helper cells that activate the B cell and the germinal centers. And in fact, adding co-stimulation blockade to plasma cell reduce HLA antibodies. And as you can see here, the B cell proliferation did not occur when belatacept was added and the follicular T helper cells were not activated, and yet the HLA antibodies decreased. And actually, something similar was reported a year previously in AGT by our moderator, Anita Chong, showing that treating sensitized mouse in the mouse transplant model collapsed allospecific germinal centers and inhibited antibody production. And so you can see here the germinal centers, unlike the control mice, when the CTL4IG was used, remained collapsed. And so for the ATTAIN trial, we designed a trial where we would use daratumumab as an anti-CD38 to deplete plasma cells, and belatacept to block helper T cell and T follicular helper cell activation and prevent B cell expansion to germinal centers as well as memory B cells. So the design of the study that was funded by ITN was to take patients who are 99.9 and higher, do a bone marrow before and do a bone marrow afterwards to study the plasma cells. And if these patients would be get transplanted, we would get a lymph node to look at the germinal center in the lymph node. The ITN funded 15 patients. So the first patient, we used 50% of the daratumumab dose that is used in multiple myeloma, 8 milligram per kilo. We showed that the plasma cells were depleted. However, we're interested to find out the various subtypes of plasma cells. The A and the B are actually short-lived, and the D population is long-lived. And they have different surface markers that can be analyzed and detected by flow. And what we showed that the A and the P population were completely depleted, but the D population, the long-lived plasma cells, we had mixed results. And 3 out of the 5 patients got transplanted. And just very quickly show you what happened with our first cohort. This is a pre-treatment HLA class 1 and class 2. Every column is one HLA antibody, and the height, the vertical axis is the MFI up to 20,000, and of course some above. You can see that the red and the orange are robust HLA antibodies that should not be crossed. The yellow and the green are the ones that can be crossed. And after this patient got desensitized, 5 antibodies were eliminated, and 7 had a reduction of greater than 50%. The patient got transplanted, had no rebound, and a year and a half later, her HLA antibody and DSA remained suppressed. So patients 4 and 5, so 3 got transplanted, 2 patients did not get transplanted. And initially, after treatment in this patient, we thought the patient had no response. As we followed the patient and the patient had not yet get transplanted, we see that there is a long-term effect that some of the antibodies that were not initially eliminated with time got eliminated. So we hope that this patient get transplanted. Now, for the next 10 patients, we thought we would want to have a more effective regimen. So the next 10 patients, we gave them 16 milligrams per kilo of daratumumab, and we added 2 more doses of belatacept. So instead of 4, 6 at 10 milligram per kilo. Now, in the top are the gray patients in the cohort 1. The bottom are 4 of the 10 that we have treated with the new regimen. Now, of the 10 patients we treated, 1 unfortunately died from hyperkalemia when she missed a couple of dialysis during while she was in the midst of infusion. 1 patient finished infusion and 7 months later died of unrelated causes. The other 8 who have responded. Out of these 8, 5 already received a kidney from a previously incompatible kidney. Now, it's interesting to see that, in fact, the increase in likelihood of receiving a compatible donor, and this is a very good metrics, I think, to assess desensitization. These patients, just like the other patients, increase the likelihood of getting a kidney from 15 to up to 28 folds. So you can imagine the potential, how quickly can some of these patients get a transplant, because many more organs can become available for them. And this is 1 patient who got treated with this regimen in the second cohort. These are the HLA class 1 and class 2 pre-treatment. After treatment, as you can see, the patient lost a lot of antibodies. 20 HLA antibodies were depleted. These were more than 2,000 and dropped to below 1,000 and could be crossed. 60 other antibodies were reduced by greater than 50%. And you don't need great changes in CPRA. The CPRA went from 99.97 to 99.53. And the patient got transplanted. In the bone marrow, we did see very good depletion. And this here these are the long-lived plasma cell, and you can see that post-therapy, almost all were depleted. And so, as I said, of all the patients that were treated in the cohort, currently we have 8 of these 8, 5 received transplant from non-compatible kidneys. So a quick word now. There is an emergence of another interesting target to plasma cell. These are the bispecific antibodies. The bispecific antibodies target 2 markers, the BCMA on the surface of plasma cells, and bind to the CD3 cell, activate the T cell for it to lyse the plasma cells. Now, currently, there are 3 agents available. 2 are approved for multiple myeloma. The third one, linvoseltamab, which is not yet approved, awaiting approval, belongs to Regeneron, and they were interested in actually using it for desensitization. There is a multi-center trial ongoing. One advantage of the bispecific is all you need, at least in our so far in the study, is to use 3 doses at 1 weekly interval. So it's much shortened the treatment regimen. Now at UCSF we have treated 4 patients, but 3 completed therapy, and all 3 after treatment got a kidney from incompatible donors. Now the first 3 here, this is the first patient. These are the class 1 and class 2 antibodies prior to therapy. And you can see that after therapy, there was a marked reduction in HLA antibody. And this patient actually got rapidly transplanted. Now, there is another bispecific, hopefully will enter clinical trial towards the end of the year. And so I think we will have different options in trying to desensitize patients. So in conclusion, novel therapies are transforming the field of desensitization, and I'm quite sure the AMR will follow. Mechanistically driven targeted therapies that inhibit B-cell activation, plasma cell differentiation, and eliminates long-lived plasma cells are required for successful desensitization strategies without rebound. The anti-CD38 and the bispecific anti-BCMA CD3 antibodies will replace rituximab in targeting HLA antibodies. And thank you for your attention.
Thank you, Dr. Vincenti.
And acknowledge all the group that was involved in the study, the ITN study for desensitization. Thank you.
Thank you, Dr. Vincenti. That was really exciting, especially your bispecific antibodies. I also want to thank everyone for submitting their questions and to encourage people to submit new ones with Dr. Vincenti's presentation. So I'm going to start by addressing some questions that have already been submitted to Dr. Vo. Firstly, the question is there are a lot of questions around the idea of what were your post-transplant and post-desensitization viremia infections, some events.
So we have a post-transplant retreatment with IVIG and anti-CD20 for all our highly sensitized patients who have undergone a transplant. And so our incidence of CMV and BK are pretty similar to our general population, about 10 to 15%. But we do feel that that is the IVIG that really makes a difference in preventing the higher incidence of viremia seen with our patients.
And I had a follow-up question. So do you see any more infections or other side effects with the treatment with anti-CD38 compared to the, your standard protocol for desensitization?
So pre-transplant with the DARA protocol, we saw a few patients with hypogamma. And we implemented a monitoring where we would check the IgG level 1 month after the last DARA, completion of DARA, and we saw a few patients with hypogamma. So those patients would require monthly IVIG for the for the treatment of hypogamma. For post-transplant, as I mentioned, they do receive IVIG post-transplant. So the incidence is comparable and that we continue to monitoring. So our monitoring parameter is monthly for 6 months of CMV, EBV, BK in our patients, and then we would treat when needed.
Yeah, great. Thank you. I have a question. I think it's for Dr. Vincenti, which is what are the side effects for you for your daratumumab desensitization versus, I guess, your bispecific antibodies?
I think both isatuximab and daratumumab have not been associated with any major side effects or infusion reactions. And, we're using them very targeted. In other words, we don't use that many agents. I mean, the isatuximab was monotherapy with daratumumab. Obviously, we're using it with belatacept. We had one patient who had low IgG below 500. We treated that patient. But so far, I think they seem to be pretty safe, quite frankly.
Oh, great. So there were some questions from Dr. Lazar, Molnar, and Rajalingam with regards to the criteria for how you calculate DSA or HLA decrease and whether you also correlated these decreases with flow cross-match or confirm these decreases with a flow cross-match assay.
Is that a question for Dr. Vincenti?
Yes. Both,
Okay.
I guess, for both of you.
Let's start.
So for us, we don't look at the we do look at the reduction of the CPR of the MFI specific for class 1 and class 2. The way we approach our highly sensitized patient is that once they're listed as a CPR of 99.99, for example, they stay at that CPRA. Once they receive the desensitization and we continue to monitor them, we will adjust the CPRA, but not to lose the national allocation. So meaning we would try to get them to that window of CPRA of 99.5 if we can. But with that said, you know, the data that I show, these patients that had very high MFI in the 13 to 17,500 for class 1 and class 2 pre-desensitization at the time of transplant, their MFI are much lower. Those that had DSA, their strength of the DSA is much lower. So that's how we monitor the efficacy of the treatment, not so much of the reduction of the CPRA specifically.
Well, I agree. I think the CPRA is not a very good indicator of efficacy. We do only virtual cross-match like so many other places. We do a retrospective cytotoxic one, you know, just for completion. But basically, patients who have a reduction of their HLA antibody from over 2,000 to below 2,000 MFI, we delete those HLAs, and therefore we can accept kidneys from those donors. And so far it appears to be pretty successful. Occasionally, post-transplant, you'll see a slight rebound of some HLA antibodies that you can treat easily with IVIG, and they come down. So we haven't seen any huge increase in rebound. We've had 2 patients who had subclinical AMR that, again, we treated with IVIG and steroids, and then they got better, and then they continue to have normal function. So we haven't had any episode of florid clinical AMR in those patients that we have so far transplanted.
Great. So I have a question from Jean Kwon and Stuart Connectley, who said that these are really exciting results. So what is your opinion, or what do you think the field should move to with regards to choosing, now that you have so many different drugs, and you know, what are your thoughts about how to rationalize their use moving forward?
Is that Stuart Connectley that asked this question?
Yes.
Stuart, well, you paved the way to some of our studies, actually.
Yes.
So a big thanks from all of us for that. Your studies are wonderful as well, Anita, is the mice. But, you know, I think the question is, which is going to be the better drug to eliminate plasma cells? Anti-CD38, that not only is present on plasma cell, but also on many B cell precursor, versus the bispecific that target maybe more effectively the plasma cells. And so I don't know, frankly, at this point. I think that's why we need to study both and study them. My preferred way is to study them without too many additional therapies, so that we know exactly what they do. As I said, the bispecific have the advantage of a short-term regimen. You give 3 doses, each one at 1-week interval, and you deplete. At least in the ATTAIN, you can see that, you know, the regimen goes over 3 months. And I think the success of the ATTAIN is a combination of the anti-CD38 with the belatacept, as you've shown in the primates, non-human primates. So time will tell. But I think targeting the plasma cell is the correct way to go, which will be the better agent and the safer agent. I think time will tell.
Dr. Vo?
Yes, I agree. I agree with Dr. Vincenti in that the anti-CD38 is what we have now for targeting plasma cells. Before our experience with anti-CD38, we were a big user of anti-IL-6, tocilizumab, as an anti-IL-6 receptor blocker. And we showed that 50% of our patients who were difficult to desensitize did respond and were able to receive a transplant. But what we found is that we have to continue to give the treatment post-transplant. And when we stop the treatment, if the insurance start to deny further treatment, we see rebound of DSA in these patients, and then they ended up having, worse form of AMR. So with that said, the anti-IL-6 therapy was promising as long as we're able to continue to give it. But with that said, it does require longer infusion, longer duration in order to get the same response. So anti-CD38 for us allowed us to transplant the patients. The cost match are acceptable at the time of transplant. The DSA that were there were very acceptable and can't be treated if there's any problems post-transplant.
Maybe I can add just one thing that since Stuart correctly asked the question, that he's doing a parallel study with the I-10 like exactly ATTAIN, except instead of eliminating cells with anti-CD38, he's using a proteasome inhibitor. But frankly, long term, I think the availability of the anti-CD38 and the availability also of the bispecific antibodies, and the fact that there are companies that hopefully will stand behind these drugs and do more trials, will prevail as the most logical and practical approach maybe to deplete plasma cells.
So I have a follow-up question for Dr. Vincenti. So with the use of the bispecific monoclonal antibodies that require T cell killing, do you think that co-stimulation blockade would be antagonistic with that function?
Yeah, well, that's an interesting question. I don't know. It could be, of course, because you're blocking T cells. But maybe it could, one of the side effects of, especially at high doses of the bispecific, is the cytokine release syndrome. And so the issue is, can you modulate these bispecific so that you get efficacy without having much release of the cytokines? And now, in the doses that we're using, hopefully we will not cross that, because we're using lower doses than what's being used in multiple myeloma. But it's an interesting thought about what would be synergistic, let's say, to the bispecific. But I can tell you one thing. I know that one of these therapy will be the main one, and I do not think that CAR T BCMA that are in clinical trials for desensitization will be as safe and as easily maneuverable as the monoclonal antibodies that you can modify and stop at any point and so on. So I think one of these regimens will hopefully come out on top, and we'll learn more only by doing more clinical trials.
Yeah, that's true. I wanted to have one comment and then one last question. So Dr. Parsons indicated that CD28 is also expressed on these long-lived plasma cells. And so the BALA could be an additional benefit to eliminating these long-lived plasma cells. And then finally, the question for Dr. Vo is, did you monitor effects of NK cells and B cells with your anti-CD38? And do you think that, in addition to the subtle drops in DSA, that there could be other effects that's making this, therapy so effective?
So that data was not presented, included here in the presentation today, but Dr. Shili Ji, who had presented the cell monitoring that was done during our DARA desensitization for these patients were presented in 2023, and she saw that there was a reduction in the NK cells. And as early as after the first dose of DARA, So yes, there are cells that are seen. So for example, the lymphocytes that were reduced from the leukocytes that you monitor, as well as the NK cells that were reduced, but the B cells were not as affected. That was seen with, at that time we only had a few patients that we started, but we did see a reduction primarily in the NK cells.
Yeah, and a quick follow-up. Did you also measure like antibodies against flu? Were they also reduced, or is it certain?
They were reduced, but not to a sub-therapeutic level. They were still in the range of the normal range, but lower end of the normal range.
Okay, great. I hope that I've got most of the sort of the classes of questions that are, and it looks as if we're almost right at the top of the hour. So I'm going to thank Dr. Vo and Dr. Vincenti for these really exciting results that they've shared with us today. And I'm going to hand back this webinar to Victoria.
Thank you so much.
Dr. Chong. Thank you, Dr. Ashley and Vincenti. We would like to thank our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey. The recording of this session will be available later this week. Thank you again.
Thank you.
Okay, thank you.
Thank
That
you
was
so
exciting.
much.